From the JAMA Network, this is JAMA Clinical Reviews, interviews and ideas about innovations in medicine, science, and clinical practice.
Hello, and welcome to this JAMA Clinical Review podcast. I'm your host, Dr. Linda Brubaker, a professor of Obstetrics and Gynecology at the University of California, San Diego Department of Obstetrics, Gynecology, and Reproductive Sciences. And I'm joined today by Dr. Tiffany A. Simas, the chair of the Department of Obstetrics and Gynecology at the University of Massachusetts. Welcome, Dr. Simas.
Nice to be here. Thank you for having me.
And if it's all right with you, we can maybe do this on a first-name basis. Is that all right with you?
I would prefer that. Thank you.
Well, let's start with a description of this problem of perinatal mental health conditions. It's a growing concern and doesn't always get the attention it needs. Could you describe the problem for us?
Yeah, so perinatal mental health conditions are mental health conditions that affect pregnant and postpartum individuals in pregnancy and postpartum. And it really encompasses any mental health condition, and it also encompasses conditions that may have had onset predating the pregnancy, but of course continue on and thus affect the pregnancy and the postpartum period. And of course, those that develop over the course of the pregnancy and in the postpartum period itself. They're incredibly common. Approximately 1 in 5 perinatal individuals will experience a perinatal mental health complication. And unfortunately, it is currently the leading cause of pregnancy-related death, so is a significant contributor to maternal mortality in the way of suicide, overdose, and accidental poisoning.
And I understand that ACOG recently updated their screening recommendations.
They did. So there's actually 2 clinical practice guidelines that came out recently, one related to screening and the other related to treatment. With regards to screening, the recommendations were such that we in OBGYN or anybody caring for a pregnant postpartum individual should be screening for depression and anxiety using a validated instrument at the initial OB visit, at some time later on in the pregnancy, which in my own practice, we translate to about 24 to 28 weeks, pairing that with the gestational diabetes screening, and then in the postpartum period. And the reason for those 3 time points is that we're looking to sort of identify early, to ideally intervene early and have a positive impact on and improving symptoms. So about 1/3 of persons with perinatal mental health conditions will actually come into the pregnancy with it. About 1/3 will develop it over the course of the pregnancy, and about 1/3 will develop it in the postpartum period. So those multiple time points are meant to kind of capture that chronology. And additionally, many seeking obstetric care end that relationship related to the pregnancy in, approximately 6 to 12 weeks postpartum. And then there are recommendations for pediatricians to continue screening at each of the well child visits.
That's very helpful. Can you give us some guidance about what to do if the screen is positive and whether there's an indication to screen for concomitant substance use disorder?
Yeah, that's a great question. A screening instrument is just that. It is a screening instrument and not a diagnostic tool. And so when a perinatal individual is given a screening instrument, like, for example, the EPDS or the Edinburgh Postnatal Depression Survey or PHQ-9, the Patient Health Questionnaire 9, which are depression screening tools, or GAD-7, the Generalized Anxiety Disorder Screen for anxiety, the score on those tools does correlate with illness severity, but again, is not diagnostic. So the next step is to really ask questions about the types of symptoms somebody is experiencing, the frequency of those symptoms, the severity of those symptoms, and the extent to which they are impacting their functioning and, approach to daily living. So yes, there's a screener. Yes, that screener can correlate with severity, but it's really that assessment, which is a conversation and an interview. Also understanding what are a person's stressors? What are their supports? What is their past mental health history? Do they in fact have a prior diagnosis, family history, medication or therapy history, or hospitalization and suicide risk? And so all of that goes into the diagnosis. Certainly, in addition to depression, anxiety, and other mental health conditions, substance use disorder is, of course, a mental health condition, but we sometimes pull that out as a different conversation, and thus screening for substance use disorders can be important. The other medical conditions that can mimic depression symptoms are things like severe anemia or significant thyroid dysfunction. And so as part of the workup or consideration of this is also considering those others in your differential.
And it's my understanding that as you consider a diagnosis of depression, it's important to rule out bipolar disorder. Could you talk about that a little bit?
I'm very grateful that you asked that question. For those perinatal individuals that screen positive for depression, almost 1 in 5 will actually have a bipolar disorder diagnosis. If we think about treating depression, right, it's treated with therapy and an antidepressant. But if you treat bipolar disorder with an unopposed antidepressant, you can actually have much more harm than good in the way of potentially precipitating mania, mixed states, psychosis, and all of those things are associated with an increased risk of both suicide and infanticide. So we need to be very cautious about that. A more appropriate treatment for bipolar disorder would be a mood stabilizer as opposed to an antidepressant. And so if you go back to the question about the ACOG recommendations, there is a recommendation to screen for bipolar disorder. Minimally, that screening should happen prior to prescribing pharmacotherapy for depression or anxiety. But one might argue, because how common it is, that you could also consider adding it right up front to your initial screens and that initial OB visit and add it to your depression anxiety screeners.
So, for mild depression, which I think is a clinical cutoff, or is that a scoring cutoff?
Well, both in some ways. So, as I said, the screening instruments, the scores of those do correlate with illness severity, and it's also a conversation. So, mild depression, the scoring cutoffs for EPDS and PHQ-9 would be scores of 10 to 14. But from a symptomatic perspective, I would associate that with things like no suicidal ideation, not feeling hopeless, helpless, or worthless, not having previous psychiatric hospitalizations, and having no or minimal difficulty caring for self or baby.
And the first line therapy for mild depression would be psychotherapy, not any kind of pharmacotherapy. Is that correct?
I would say in general, yes, psychotherapy is the first line. However, it is shared decision making and really a conversation about the whole person and what their values and desires are. So, for example, if you have somebody who currently is having mild symptomatology, but they previously have had depression that required pharmacotherapy treatment, they may want to initiate that again. Or if they don't have access to psychotherapy, or it's a long wait to get to psychotherapy, or it's just unavailable, then you may want to consider pharmacotherapy. So it's certainly it's a risk conversation around the risk of untreated disease versus the risk of treatment.
Well, let's talk a little bit about the pharmacotherapy options and what kind of the stepwise approach would be.
So to date, the first line pharmacotherapy, most commonly prescribed medications fall into the selective serotonin reuptake inhibitors, or SSRIs, and serotonin norepinephrine reuptake inhibitors, SNRIs category. And those have been very, very well studied in pregnancy. And in general, it's felt that if you're having that, as I said, risk conversation, what are the risks of untreated disease versus the risks of the pharmacotherapy and the benefits of the pharmacotherapy, more often than not, in that conversation, it is worthwhile and in the best interest of the perinatal individual to proceed with the pharmacotherapy.
And these medications have a reasonable safety profile, but could you talk a little bit about their side effects?
They do have a reasonable safety profile. From a side effect perspective, you always want to start at the lowest dose, but the lowest dose is not a therapeutic dose. It does require up titration to get to a therapeutic window. And so slowly up titrating can diminish some of those side effects. Side effects that are common include things like nausea, dry mouth, diarrhea, headache, dizziness, agitation. Many of those are temporary and we do anticipate will resolve. So if you start low, kind of go up slow, you can mitigate some of them. And over a course of days to weeks, we would expect them to resolve. Some of the longer term side effects that may not be transient, that may be persistent, are things like sexual dysfunction.
And these are prescribed for use during pregnancy, and are they okay to use during lactation?
They are prescribed in pregnancy and in lactation. There are some of the SSRIs and SNRIs that have lower translactal passage. So, for example, sertraline tends to be a commonly prescribed drug. It's one of the most studied in pregnancy and in lactation, lowest translactal passage.
So, if a patient doesn't have the desired symptom relief from those medicines, or they have more severe symptoms, moderate or severe depression, what pharmacotherapy would you recommend?
So, for moderate and severe depression, again, to date, the SSRIs and the SNRIs are really the best studied, and they're tried and true. The literature is full of information as it relates to pregnancy and postpartum. And so those still would be very much, considerations for prescribing and for effectiveness. They do, the SSNRIs, the SSRIs do take a while before they do achieve therapeutic effect. What is relatively new is in approximately 2019, a new medication called brexanolone was FDA approved. It is a synthetic neuroactive steroid, a synthetic allopregnanolone, and it is a positive allosteric modulator of a GABA A receptor. And so a completely new and novel method of action or mechanism of action. When brexanolone came out and it is still available, it is administered as a 60-hour IV infusion. So it does require a approximately 3-day hospital stay. Inpatient, it does require pre-approval, and many places don't administer it. So it is somewhat limited in its availability and in perinatal individuals' ability to access it, along with a relatively high price tag.
And how about the use in lactation?
All persons that received brexanolone in their studies had to stop lactating, putting the infant to breast during the time of the medication administration and for a period of time afterwards. So we really have minimal information about that. So the recommendation would be to not breastfeed or chest feed during this time.
And I understand there's a medication that has recently been approved. Can you talk a little bit about this newest development?
Yeah, in August of this past year, the FDA approved a medication called zuranolone. It is an oral version of the prior brexanolone. That was the IV version that was approved a couple of years ago. Mechanism of action is very similar. Administration is quite different. Rather than having a 60-hour IV infusion inpatient, this will be a single oral administration daily for 14 days consecutively.
And what's the evidence for efficacy and how is it prescribed?
So there were 2 phase 3 placebo-controlled multi-site randomized controlled trials that led to the FDA approval of this medication. And so it's prescribed at 50 milligrams once a day in the evening. And we can talk about specifically why in the evening with a fatty meal and over 14 days. And I referred to in the evening. So the reason that it's prescribed in the evening specifically, it has some pretty significantly sedating effects, such that for at least 12 hours following oral intake of the medication, one should not drive or do any other activity that would require, clarity of thought, mind, and complete cautiousness. So driving would be one of those risk activities.
So although this may be a welcome pharmacotherapy option for some people, others have some concerns about this medication. Can you talk about that just a bit?
Yeah, there are a couple concerns. One is that the study endpoints were at day 15, basically the 14 days of administration, then on day 15, looking at depressive symptoms, of which there was significant improvement as early as day 3. So from an efficacy perspective, it does what it was intended, or at least it seems to do what it was intended. And that effect seems to be durable out to at least 42 days, right? So at least 4 weeks past the initial dose. However, there are no studies beyond the 42 days. So is the impact really durable for an extended, prolonged period of time? Will the depression go into true remission, or might it return after the end of the 42 days? That's one of the potential concerns. The other is if you look at the methodology of the studies and the eligibility criteria for who was able to enroll. The HAM-D, which is the Hamilton Depression Screening Tool, was the metric by which depressive symptoms were measured. And so a score consistent with basically severe symptomatology or disease severity is what was required for eligibility into the study. When the FDA approved zuranolone. It was really for postpartum depression for adults with no qualifiers on severity, and the studies really did not speak to that.
That's an important information for our listeners to consider if they wish to prescribe this medication. So this is an area there's much more work that needs to be done. Let's just close with some consideration of the scope of untreated peripartum depression. This is still a significant problem, isn't it?
It is a very significant problem. So untreated perinatal depression is common, meaning we don't pick it up nearly as often as we should, and those even in whom it is detected often don't access treatment. The last significant data as it relates to this says only about a quarter of individuals with recognized disease get treatment access, and that's not adequate treatment access, or that's not treatment to remission. That's purely treatment access. And so we have a long way to go as it relates to really systematically and universally identifying those who are experiencing perinatal mental health conditions and getting them not just into treatment, but actually treatment to the point of symptom remission. And in this context of not achieving that, it remains a significant contributor to maternal mortality.
That's very, very concerning. What are some of the resources that are available to patients and their clinicians?
I think one of the newest resources that is incredibly helpful are what are called perinatal psychiatry access programs. Access programs were created acknowledging that there are many clinicians who are uncomfortable addressing mental health conditions in pregnant and postpartum women or individuals, and they are really meant to help increase the capacity of us as clinicians to address this. So in many states across the nation, there are access programs in which you can pick up the phone Monday through Friday during usual business hours and ask to speak to a perinatal psychiatrist about the very specific patient that is sitting with you and get guidance on how to address their needs and give them access to care and treatment.
That's very, very helpful. I'm Linda Brubaker, and I've been speaking with Dr. Tiffany Simas about peripartum mental health conditions. You can find a link to the paper in this episode's description. To follow this and other JAMA Network podcasts, please visit us online at jamanetworkaudio.com or search for JAMA Network wherever you get your podcasts. This episode was produced by Daniel Morrow at the JAMA Network. Thanks for listening.